Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation. I'm pleased to welcome you all today to this webinar, Reaching Minorities, Healthcare Enrollment and Engagement. With less than 2 weeks until the start of the third health insurance marketplace open enrollment period, we're pleased to have an excellent panel of experts with us today to share their perspectives on opportunities to increase coverage among minority populations and improve health literacy among the newly insured. Before we hear from them, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, who led the development of today's webinar, as well as the NIHCM staff who helped to convene this event today, including Kate Ellis, Katie McDonald, Carolyn Myers, and Kirsten Wade. You can find biographical information for all of our speakers along with today's agenda and copies of the presentations on our website. We also invite you to live tweet during the webinar today using the hashtag #MinorityHealth. I'm now pleased to introduce our first speaker, Dr. Cara James, Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. We're so honored to have her with us today to share CMS's efforts to help consumers select and utilize coverage. Dr. James?
Thank you, Catherine. It's great to be here and to talk today about our important topic as we are leading into open enrollment. So as we start open enrollment, it's worth noting that we're continuing to build on the progress that's already been made. Millions of Americans have obtained coverage through our first open enrollment periods, including about 2.6 million African Americans and 4 million Latinos. But we still know we have work to do. Millions of Americans remain uninsured, and many of them are people of color, including, as we go forward, about 10.5 million that we expect to be eligible to enroll in 2016, which includes 1.5 million African Americans and 2 million Hispanics. One of the important aspects of the gains that we've also seen includes improvements in access to care. And we've seen that over time that we've seen decreases in the percentage of individuals who are reporting that they don't have access to a personal physician, and small decreases in the proportion of the population who are saying that they have no easy access to medicine. But for many individuals, these gains are not as large as those that we have seen in coverage. And one of the big drivers towards some of these bigger changes in access includes making sure and retaining people as they go through re-enrollment to improve those access changes. And it's one of the reasons that we started the initiative From Coverage to Care. And as we know, for millions of these individuals who've obtained coverage, for many it's the first time or the first time in a long time that they've had coverage. And they may not be familiar with important insurance terms or how to use it to get the care they need. And as you can see, From Coverage to Care is an effort to help educate consumers about their new coverage and connect them to the primary care and preventive services that are right for them. As we know, for many people, it's important to have in-person assistance and to build on those trusted networks. And Coverage to Care builds on those existing networks of community partners to help educate and empower newly insured individuals because they are the trusted resources in the community. We launched Coverage to Care in 2014, right after the end of the first open enrollment period, and we developed a suite of products to help consumers understand their insurance information and to be able to connect to care. We have an enrollment toolkit, which I'll talk about as we gear up for open enrollment, as well as a roadmap and a discussion guide for our community partners who are talking to consumers. And as we know, individuals learn materials in different ways, so we also have developed video vignettes. I know that individuals are interested on the call in learning about where they can get resources, and I wanted to share with you that all of the resources are available to order as well as to print and download through our website at marketplace.cms.gov/C2C. One of the important pieces of connecting people to coverage is making sure that they are to care is to make sure that they start with the right plan. And as we learned at the end of the first open enrollment period, many people selected plans based on cost. but we also know there's a lot of basic information about coverage that has not reached a number of the uninsured. So we developed the Enrollment Toolkit to help our community partners who are working to enroll individuals in coverage be able to talk to them to help consumers pick the plan that best meets their needs and their family's needs. It includes 5 sections that you see here. Due to the time that we have, I'm not going to go through each of them, but I will highlight some of them. And again, you can order copies of the roadmap as well as view it on our Marketplace website. So one of the things that we know is for many consumers, they're still trying to decide why they should get coverage. Many are interested in it, but they don't know in many cases that it's more affordable than they think. Recent data has shown that nearly 6 in 10 of the uninsured have less than $100 left after paying bills each month, and 8 in 10 said they could not afford their coverage. Interestingly, though, 6 in 10 have not heard about or do not understand tax credits and are not looking at coverage as a result of that. And many of the uninsured have not even visited the marketplace to find out more information. So as we're talking to consumers, I think for many of the uninsured, we still have an important message to get out to help them understand why they should sign up for coverage. And the Enrollment Toolkit also includes additional resources at the end of each section to help you as you're talking to consumers, talking about incomes that qualify for lower costs, as well as how to estimate incomes for the marketplace. One of the other sections that we include is what consumers should know when picking a plan. We talk about some of the differences between premiums and actual costs, review provider networks and encourage consumers to check and see if their provider is in a network before selecting a plan. We also help consumers to understand their prescription drug coverage and to talk about whether or not they're interested in dental or vision coverage. Some of the resources in this section include explanations of the meta levels and how they can find information on the healthcare providers in the networks they're considering. Finally, and really relevant to the call today, we include a section on special circumstances in working with populations such as American Indians and Alaska Natives, individuals with limited English proficiency, and individuals in immigrant status to help understand what they have needs for and how to help them. We include a glossary of healthcare terms for consumers with limited English proficiency, as well as more resources on helping other populations, including people with disabilities and sexual and gender minorities. So that was a very quick tour through an enrollment toolkit. We do encourage you, as you're working with consumers, to talk to them and to look through it, share some of the resources that may be there and help you as you're communicating with consumers about the importance of getting coverage in this open enrollment period and maintaining their coverage if they've had it already. So we move from there. Once we have individuals enrolled, we want to help them to connect to coverage. As you remembered some of those gains I showed you earlier in terms of access to care, we want those gains to grow even larger, and helping consumers understand their coverage and be able to connect to care is one way in which we can do that through our Coverage to Care roadmap. It's a booklet also available on our website. It includes 8 steps. Because of our limitations in time, I'm not going to go through all 8 steps, but just wanted to highlight some of the things that we had in the roadmap. First is step 1, and it includes putting your health first. And this was an important step because as we were developing the roadmap, we talked to consumers, both insured and uninsured, providers, as well as policymakers and other community partners who worked with uninsured to help us think about what were the pieces and the messages we wanted to understand. And for many individuals who are uninsured, they understand the importance of having coverage as something to use when they get sick, but may not think about how they can use their coverage to stay healthy. So we developed step 1 of putting your health first. We talk about messages of staying healthy is important for you and your family, how to maintain a healthy lifestyle, learning what they can do to stay healthy and sharing that knowledge with their friends and family, as well as the importance of getting recommended health screenings and managing chronic conditions. We also encourage consumers to take an active role, and one of the steps where we've developed more information is putting your health first, taking an active role in your health care. We encourage consumers to be active in their health and how that can lead to better care and better health for their family. We also provide some resources to encourage consumers to keep track of their health information and to ask questions. In our second step, it's understand your health coverage. Some of the information covered here is also covered in our Enrollment Toolkit, but this really is to help consumers understand some of those key insurance terms, such as copayment, coinsurance, and deductibles. We encourage consumers to review their plan to see what services are covered, to make sure that they know the difference between in-network and out-of-network, and to help them understand their out-of-pocket costs. Throughout the roadmap, you'll notice that we have boxes that we call cost tips, and some of the feedback that we received when we were piloting the roadmap is to help consumers understand the financial implications of some of their choices and their health behaviors. So we've put those throughout the roadmap to help people with that information. Step 2 also includes an example of an insurance card to help consumers become familiar with where they can find that information as they call to get questions from their plan or if they call to make an appointment with their provider. Step 2 also includes a couple of examples of cost tables to help consumers see how their deductibles, co-payments, and coinsurance can come together if they are, for example, having a baby or managing type 2 diabetes. Again, these are not real costs, but just an example. In step 3, we focus on knowing where to go for care. We want to encourage consumers to really use the emergency room only in life-threatening illnesses or injuries, and to really focus on primary care for most of their health care needs. Some of the questions that we ask in focusing are, do you know the difference in the cost that you could have associated with care received from a primary care provider versus the emergency department, and how your care might differ. We include a table, and this table is also available as a one-pager for consumers to review that talks about some of those differences between primary care and emergency care. Again, taking that feedback that we received about helping consumers understand their costs, the first line focuses on some of those cost differentials related to the primary care copayment typically being less than that for the emergency department, and some of the other costs that you could be susceptible for. We also talk about further on down that you can call and make an appointment for your primary care provider, whereas that's not generally the case in the emergency department. And we focus on the fact further down that your primary care provider will often focus on more than just what brought you in for that day, whereas in the emergency department, they really are going to focus on the urgent problem of the day. And again, just really emphasizing to consumers about the importance of utilizing primary care provider rather than the emergency department for non-life-threatening illnesses and injuries. Steps 4, 5, 6, and 7 talk about how to find a provider and being prepared for that appointment. Step 7, because we want to encourage consumers to develop a long-term relationship with their provider, encourages them to think about whether or not the provider is right for them. And for many of our uninsured individuals who may not have had positive experiences with the healthcare system, for many when we piloted this, they found that this was actually a very important piece of information that they didn't know. As one consumer said during our pilot, they didn't know that if their provider that they selected turned out to be Frankenstein, that they had a choice. So we want to encourage consumers to understand and review whether or not the provider is best for them, whether they meet their needs, for example, with language access or accessibility, and if not, to work with the provider or to change if they so desire. In our final step, we talk about what to do after their visit. We encourage consumers to write down in their provider's instructions so they understand what they should do when they get home, to schedule any follow-up visits, as well as fill any prescriptions. And we encourage them to review their documents and to continue paying their premiums if they have them so that they can maintain coverage. We also include in the roadmap an example of an explanation of benefits, emphasizing that while this is not a bill, it doesn't mean that they won't get one. And we try to help consumers understand their information and be able to read it so that if they have questions, they can follow up with their health plan or their provider. The roadmap also includes additional information, such as a fuller glossary of health coverage terms. We include a resource list of other resources that have been developed by some of those in our federal family. We also include a personal health tracking checklist to get consumers to understand some of their specific health indicators. And finally, on the last page, we include health information, such as their coverage and provider contact information. We have worked with our community partners to translate the roadmap into 7 languages, as you see here. Includes Spanish, Arabic, Haitian Creole, Russian, Chinese, Vietnamese, and Korean. And we also have worked with our tribal affairs group to develop one that is unique to the individuals who are members of our tribal communities. Again, all of these are available for free through our Marketplace website. And we continue to develop additional resources because we know that as individuals come into coverage and are entering the system maybe for the first time or the first time in a long time, it's going to be a process, and that we will continue to need to support them as they journey from coverage to care. We also offer for the roadmap an opportunity for those of you who may be interested to customize on our website the inside covers and the back covers of the roadmap to add local information or information about your organization if you're a navigator or assister or helping individuals enroll, to provide some of those local resources. And that's available again through our website under the roadmap, and you can see the other products we have listed. So as I close and sort of think about what you can do, we encourage you to share the resources. We know that many organizations have customized some of their own resources or developed theirs, but this is an important piece of helping our consumers understand and retain them throughout open enrollment and throughout the year to retain their coverage and come back to sign up again. We encourage you to customize them to your community. If you're hosting local events or doing outreach, to consider incorporating the roadmap in. And each state, as we know, is very different within their Medicaid and CHIP offices, so we encourage you to work with them to tailor some of the resources to your specific state, and to think about ways to engage providers and issuers. And finally, to let us know what works. As we said, we've had millions of individuals who've gotten coverage. We still have millions more, and we will be here to support them as they move forward in their process. So as I close, just wanted to share with you resources, a link to the Marketplace website, and if you have questions, to please email us and provide us with your feedback. Thank you.
Thank you so much, Dr. James. Our next speaker, Jose Plaza, has played a key role in the coverage gains that Dr. James mentioned earlier during the previous 2 Marketplace enrollment cycles in his role as Director of Latino Engagement at Enroll America. And he joins us today to share strategies and tools for reaching the remaining uninsured, as well as improving health literacy among communities of color. Jose?
Thank you, Catherine, and thank you everyone for joining us today, and thank you to Dr. James, who touched on some of the things that I'm going to be talking about. So I'll go briefly over those numbers again, just so that folks get an understanding of the great work that we have done in coalition and in partnership. As we have seen, there has been an 11% drop in uninsured Latino sets, over 4 million. Overall, folks might think that that's not a big amount when it comes to the millions of Latinos. The baseline uninsured rate that we started at for Latinos was 41 million. But over the last 3 cycles, now going into the 3rd cycle, we've seen a percentage drop of 11%, so that has brought down the number to 30 million, including states that have expanded. So the drop in an insurance rate for Latinos has been great, outside of the multiple barriers that both Latinos and the general community of color tend to be impacted with. Notwithstanding, the African American community as well has done great leaps and bounds in terms of dropping the rate of uninsurance rate within their community at 2.6 million. Again, there are some similarities when it comes to the challenges and barriers within communities of color, but there are some nuances in terms of how we've done outreach and really have reached this number, which is great in terms of bringing it down from 22 million down to 12 million of African-American community members that are uninsured. As Dr. James mentioned in OE3, we have an opportunity and a challenge of ensuring that 10.5 million uninsured get access. And so out of this, we have a third of these folks that are people of color, 19% of those are Latino, 14% of those are African-American, and almost 40% are living within the 140 and 250% of the federal poverty line. What this means is that we're no longer necessarily looking at the lowest quadrants of income. Now we're looking at middle income folks who might not be enrolling for various reasons. And so looking at how we're going to be shaping our outreach will somewhat be different moving forward. So in looking at some of the persistent barriers to enrollment and understanding why it is that Latinos and African Americans and different folks from communities of color are not enrolling, we see that folks do want to have insurance. Latinos, Spanish-speaking Latinos, rate having health insurance as very important in our most recent survey that we did with Perienda. 63% of Spanish-speaking Latinos still prefer in-person help, and this goes across the board in communities of color. Folks don't want to just answer questions over the telephone or over the website or give out issues that they might be having in terms of health. And so they prefer in-person help with folks that speak their language and look like them. And this, without surprise, leads us to the next stat, that 80% of those who did not visit the marketplace were Spanish-speaking Latinos. Obviously, we have some issues in terms of access to technology and language, but for the most part, it's this lack of trust that they have of just going online or calling the 1-800 number and giving their information. And lastly, we have found that 77% of Spanish-speaking Latinos do not understand the tax credit. And so this hits directly at this idea of folks that are enrolling don't necessarily understand what they're enrolling in. And so when dealing with health insurance literacy, there are different entry points that we need to be able to target so that folks, one, know what they're enrolling in, but are making the best decisions when choosing a plan to then ensure that they will re-enroll and make sure that this enrollment cycle will be successful moving forward. So what is working when doing outreach to communities of color? And this is very important as well as I go into the slide around health insurance literacy. The messaging through traditional media has been the #1 way of reaching to communities of color. TV, radio, and print, although very expensive, it's what works. Here at Enroll America, we've hosted over 1,500 events in the community. One of the largest events we held in Texas, we had over 900 families show up. And primarily, folks showed up because they saw something on the news or they heard it on the radio. And communities of color are still the #1 group in terms of readership of newspaper. So sticking to the traditional ways of communication works with communities of color. The other thing we found was that trusted surrogates are the best messengers. We have different campaigns around our healthcare in the pulpit in which we've not only trained, but have worked with faith leaders to develop and deliver messages that resonate with their specific community. We've engaged local personalities, doctors, educators. We just wrapped up a back-to-school roundtable across the country where we brought in principals and superintendents that are trusted members of the community to have them do the talking and deliver the messages because those in the community know specific folks that they trust. Again, in-person assistance is key, but making sure that that in-person assistance is both linguistically and culturally competent is of utmost importance because if a community member is not going to see themselves in the folks they're working with, they're not going to trust them and they're not going to go back to them. And another big component within the community is word of mouth. What we found out is that we've hosted events and we would host it on a Saturday, and for the 2 weeks after that event, folks would keep on showing up because they heard from a neighbor, from a family and a member that at that library or at that church they were doing enrollment. So word of mouth is critical when it comes to the community, reaching communities of color. Lastly, in order to host events, to provide this in-person assistance, it's important that you go to venues that are trusted within the community. So going to churches, going to schools, going to libraries, places that are accessible and that are easily reached by the community or that they go to often is very important. We engaged a lot of hospitals. That was kind of hit or miss. We thought that folks would want to go to a hospital since we're talking healthcare and whatnot. But some folks actually said that hospitals were a little too cold for them. They felt a bit disconnected. So finding places that are welcoming or where folks feel that they can sit down and be there for a couple hours is also very important. And lastly, messaging must be simple, clear, and linguistically and culturally competent. As we saw from the coverage to care material, things are simple, they're direct, and so we have to make sure that whatever type of messaging that we put out there is simple and clear. So when talking about health insurance literacy, and again, talking about this outreach and when it is that we're supposed to reach the consumer but ensure that they're understanding the material, Dr. James went through 8 excellent steps, and so we developed a 5-point framework for folks to ensure that consumers are understanding. So in order to really get at health insurance literacy, we have to understand the most persistent HIL gaps among the remaining uninsured and newly enrolled. Dr. James talked about some of those, but they're going to vary from community to community. Some folks are not going to understand tax credits. Others are going to need simple definitions of terminology. So understanding what the gaps are and how they impact each community is very important. We have to be able to define what information consumers value about health insurance and how to use coverage. We found out that folks don't usually care about their health insurance until they need it or until they're sick. And so finding that point of entry is going to be very important. And understanding that for some folks, having insurance is just having insurance. For others, it's a consistent factor in their income and consistent care, especially if they're sick. We have to uncover the best times to expose consumers to information about health insurance in order to positively affect their behavior. Again, this goes to the idea of word of mouth and how we need to be very, very specific and targeted in terms of when we expose consumers to this information. The best time that we have found is when folks are enrolling or when they are going to have follow-up sessions, either for paperwork or when they're actually going to be needing care. Those are the perfect times to actually talk about terminology and what this all means for them. As well as we have been finding, working with tax preparers, and when folks are filing their taxes, that is another great time because they're actually attentive and listening to different components. And lastly, we need to determine what messengers consumers want to hear from. The work that we do in Tulsa, Oklahoma to Phoenix, Arizona is very different, especially when working with rural communities or Native American or dealing with a mixed status household within Latino or Vietnamese community. So understanding who is the perfect person to go into that home or to welcome them to an event is very important because folks will pay attention, like I said, to folks that look like them, that speak like them. So understanding who the best consumers are, the best messengers for the consumers is very important. Again, tools that address health literacy are very important. Here at Enroll America, we've developed a couple of different tools from calculators to local connectors where folks can actually find in-person assistance. If it's at noon at 11, we can help them find an in-person assister in their area within a 25-mile radius. And one of the things that we're going to be launching this November is a really nifty tool, which again, when addressing health literacy, folks need to understand not only what their premium is, but they need to understand what the yearly cost is going to be, as well as understanding things like preventative care, who their primary doctor is going to be, what prescription drugs are covered. And so in this new tool, we have all that when folks are looking to buy different plans. We break everything down, so it's like if you're on apple.com, if you're on different websites, and you're comparing different products, we've actually modeled that tool around this. And again, we're aiming that this tool is culturally linguistically competent and that we're breaking down complex terminology at that point of entry when folks are looking for it. And another thing that we're working very hard is to ensure that assisters, those folks that are actually doing this work, one, have expertise in the plans, as well as they are culturally and linguistically competent. So we've been working with foundations to actually host a series of trainings across the country to ensure that folks are understanding, one, themselves, the plans, but then also being able to understand the needs of a specific community. And then we're also relaunching our communicators program, which works, again, to train and work with trusted surrogates and messengers in the community to ensure that whatever messaging they're giving is not only timely and correct, but it's also culturally and linguistically competent, especially as we're finding going into OE3, that the focus or the interest in ACA is starting to dwindle, especially as it becomes less and less political. And so we need to keep attention on the ACA because, as we mentioned, we still have 10.5 million more Americans to sign up for OE3. And last but not least, I kept on saying that messaging must be simple and clear. What you see on the screen now is a copy of our latest brochure, which, again, goes to my point. It gives you a specific price. It gives you the 4 out of 5 folks that ever signed up have found help, in-person assistance. So the messaging that we're providing is simple, it's clear, and it's direct. We highlight the deadline. We highlight that local help is available. Again, reinforcing the idea that folks can find help in person and that it will be affordable. And so for me at this point, it's all I have. But folks can visit our Get Covered America site as well as our Enroll America site to find these tools. If you all want to find different ways of embedding these tools, they're completely free. If it's a calculator, if it's a connector, all these tools are available for free to your own consumers or with folks that have assisters and navigators within their realm. But that's it for me. Thank you.
Thanks, Jose. We had just a clarifying question. If you could explain a little bit more about the test questions that you mentioned and where are they being asked, and a little bit more about kind of the city, state.
Which one was that? Sorry.
I think she was asking about the tool, your new toolkit, and developing that.
Yeah, so that one's going to be launching November 16th, and that is available online. Folks are able to embed it. It is a widget, and so it's a live tool where folks can go in there and compare not only prices but be able to find if you have a doctor, if it's in your network, and folks can use it across the country. And it is basically just that, a comparison tool.
Okay. And you mentioned that there's been some trainings, but people that are interested in learning more will also be able to go in and learn more about it and use it as well.
Correct. And these trainings, they're meant, for every level of organization. If it's a true grassroots organization to working with more grass top. So we have basic training from dealing with messaging to, how to table, how to set up an event, to more specific ones dealing with data and how to make data work for you. So it's the levels of training do vary, but they're available for all organizations and individuals.
Okay. Another question, you mentioned the use of traditional means through the newspaper, and we had another question that came in about digital tools and sort of texting and social networks, and can you talk a little bit about how those have been used or how they might be used going forward to reach some of these harder populations that we haven't been able to reach yet?
Sure. So we saw in traditional social media and texting and whatnot, it had the largest impact on young folks, especially bilingual Latinos and young African Americans. And we actually saw the highest drops in rates of uninsurance in young Latinos. And it was through that social media and text messaging campaigns that we had. We saw the most gains in social media versus text campaigns. And that is because we also found that in order to get someone to actually take action, it took 3 to 4 actual touches So a text message wasn't necessarily sufficient, neither was just an email. So everything from Twitter to Facebook to Instagram, we've done something of the sort. But what we're also finding is that for traditionally aged folks, that's where traditional media comes in. So working with local surrogates, local TV stations, doing phone-a-thons, there is an age difference when doing this type of outreach. We're moving forward with both because, again, we understand that it takes multiple touches, but traditional media is the most expensive. But that's where we're working with local entities to try and get some earned media as opposed for paid media.
Great, thank you. Well, we have more questions, but before we get to them, we do have one final speaker today, Dr. Derek Robinson, who's Vice President for Enterprise Quality and Accreditation at the Healthcare Service Corporation. Dr. Robinson, are you with us?
I am with you. Good afternoon.
Thank you. Well, thanks so much for joining us today to share a little bit more about how partnerships can increase enrollment as well as your efforts to improve health literacy. So I'll turn it over to you.
Great. Well, thank you very much, and excited to have an opportunity to be here and participate in a panel today and share with you our story of outreach and enrollment efforts aimed at minority populations in Illinois. Again, I'm Vice President for Quality and Accreditation at Healthcare Service Corporation, which is the parent owner of Blue Cross Blue Shield of Illinois, Texas, New Mexico, Oklahoma, and Montana. I'm pleased to participate in this distinguished panel today with Dr. James as well as Mr. Plaza. We called our campaign in Illinois the Be Covered Illinois, and it's been a real source of pride for our plan here at Blue Cross Blue Shield. And first, I should probably give you some background on how we even got to this point. So in May of 2013, the state of Illinois announced that it had received a federal grant totaling $115 million, of which $35 million of it was earmarked to finance a public awareness and education campaign about the Affordable Care Act and the Illinois health insurance marketplace, Obamacare enrollment in other words. That marketplace would launch in October, 6 months away. And the Obama administration said that states could use these grants for marketing activities that included production and distribution of brochures, direct mail, print ads, social media, and digital online ads, as well as TV and radio buys related to promoting a local state exchange. And by any measure, $35 million represents a significant marketing and advertising effort. Now, we were the first to step forward and commit to offering insurance plans on our state's exchange, and only a few other carriers stepped forward. And keep in mind that back then, insurers did see real risk to insuring a population of uninsured that no one really knew. And so most commercial insurers sat on the sidelines to see what would happen. And as the state's largest insurer, however, we were all in, but we also recognized that there were some risks that existed there as well. If there were one major concern that we had, it was what if we threw this big party along with the state and nobody showed up? And like a political campaign, we had to get people out there and signing up. And in terms of our interests, we needed a critical mass of numbers to help spread the insurance risk. And at the same time, we recognized that we also were the home state for President Obama. So we had to be sure that the state did not miss out on its mark. Meanwhile, polling found that huge numbers of the public either didn't know much about the Affordable Care Act and what was in it for them, or they still thought that it was struck down by the courts. And here we had a matter of months to turn that around. We had a real sense of urgency. So in March, 2 months before the state announced its marketing grant, we'd been contacted by Congressman Danny Davis and invited to participate at one of his community health forums in April with the goal of explaining the Affordable Care Act to more of his constituents on Chicago's west side. We committed to using that as our launch for Be Covered Illinois, and we offered an exclusive to the Chicago Tribune, which featured it on page 1 of that week's Sunday Business section. Now, while other states were quick to brand their exchanges like Kentucky's KY Connect, we knew that we couldn't be idle and wait for the great state of Illinois. So in fact, it wasn't until July 12th that Illinois awarded the contract to Hilliard advertising, and by then the Be Covered Illinois was in full swing. So what was Be Covered Illinois? Simply put, it was an unbranded outreach and education campaign designed to mobilize and enable community groups and social service organizations. It's important to note that it was unbranded. Nowhere will you find any reference to Blue Cross and Blue Shield of Illinois, not a logo, not a mention of products, and that was a really deliberate effort on our part. It was our goal to truly provide education and not marketing, and we needed the help of the community partners to deliver this messaging to their constituents. Now, many were also serving under federal grants as navigators or in-person counselors, and they would have had to been sure to steer clear of any materials that were not seen as entirely objective. So we began with just 3 such organizations: the Illinois Maternal and Child Health and Disability Advocates, and the Illinois Coalition of Immigrants and Refugee Rights. By the time 2013 closed, we had counted over 75 organizations representing a broad swath of organizations. We had Kappa Alpha Psi fraternity, Delta Sigma Theta sorority. It was truly a broad-based effort involving social organizations, religious organizations, and the like. So all of the materials, brochures, websites, flyers, videos, were all bilingual in English and Spanish. Later, the campaign added translated materials in Arabic and Tagalog. In all, more than 280,000 printed materials were distributed, primarily at 220 plus events that Be Covered hosted around the state. And you find Be Covered in the Mexican Independence Parade, at the downstate county corn festivals, and even on the radio, as we had some of our other physicians and subject matter experts interviewed on WVON, which is the longest standing African American radio station broadcasting from Chicago's South Side. Now, the 75 organizations and some of the logos that you see on the screen here were really folks that were hungry to equip their teams with accurate information. And Be Covered Illinois really filled a void that had yet to be taken up by the state. So through September of 2013, we were about the only game in town, the only ones distributing information to people about what's in it for them in the Affordable Care Act and why they needed to sign up for coverage. And because we were most involved early on with education and outreach through Be Covered Illinois, it garnered a lot of media attention. And at one event held in October at the beginning of open enrollment was a Be Covered Care Fair. And it garnered media coverage from 14 separate outlets, including Spanish language media, TV, radio, print, and more, and it was certainly newsworthy. We had over 5,000 individuals in attendance, literally individuals lined up outside the door and around a corner. We offered, in addition to the educational information, free vaccinations for flu, tetanus, diphtheria, as well as health screenings. And the first 2,000 attendees received a bag of healthy, fresh groceries. We also played host to 15 social service organizations that were staffing the enrollment area, with 52 registered state navigators there to help. At that time, this was the largest gathering of certified navigators at any one event in the United States. Another target for our group were Chicago's faith community and the many large, predominantly African-American congregations, as well as large Latino Catholic parishes. We had our community outreach teams out speaking at inner-city congregations, at their Sunday services, and health fairs. We also hosted breakfasts at our offices for prominent ministers across Chicago's west and south sides to encourage them to pass along information to their membership. Our team left flyers, posters, brochures, and postcards at government offices, public transportation sites, over 250 prominent businesses at laundromats, banks, currency exchanges, and pharmacy chains like Walgreens and CVS. So it was hard to find a place where we were not at. Within a matter of months, the effort saw 81,000 website visits and downloads. Our social media presence was strong, with over 17,000 increases in our Facebook likes. We directly reached over 900,000 Illinoisans across the state. And what does all this mean in terms of outcomes? The federal projected goal in year one was an enrollment target of 143,000 people in Illinois. When it was done, the state has signed up over 217,000, surpassing the original goal by more than 50%. And about 80% of new enrollees received a federal subsidy to pay for their coverage based on their income. Then we had another 287,000 people in Illinois who signed up for the newly expanded Medicaid program. So we like to think that our Be Covered Illinois campaign did its share. I mentioned that many states branded their exchange efforts well ahead of the October enrollment. In September, the month before Illinois' ad agency unveiled their new branding, it would be called Get Covered Illinois, and used coincidentally orange, white, and blue as its color scheme, the same as Be Covered Illinois. So imitation is the highest form of flattery, as they say. We were pleased to ultimately work in partnership with the state. Obviously, our 2015, 2016 focus, we're really looking at the newly insured, ensuring that folks understand how to use insurance, the impact of personal behavior on their health, as well as the use of healthcare resources, how to find physicians and other healthcare providers that are in network, some of the nuances of prescription drug use and access, and also where folks can seek resources and access to care both in a primary care setting as well as when it's appropriate to seek emergency care. So again, we are excited to be a leader in supporting improved access to insurance coverage in the retail market. And again, we have a very strong national presence in terms of our commitment to ensuring that individuals who are uninsured have access to coverage through the retail market. So thank you so much for an opportunity to participate in today's presentation.
Thanks, Dr. Robinson, and to all of our speakers for their excellent presentations. We're excited to now engage in a Q&A session with our audience of healthcare decision makers from policy, business, and government. And at this time, our operator will explain how you can ask a question if you're joining us by phone, and you can still submit questions online as well.
At this time, I'd like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. As a reminder, if you are listening via computer, we ask that you turn your speakers off before asking your question. We'll pause for a moment to compile the Q&A roster.
Great. While we're waiting, I'll ask a question that was submitted. We had quite a few questions come in about sort of health literacy and how it's impacting enrollment. Sort of a broader question is, what are the opportunities either for the education system or other systems that can help us better prepare and work with providers or with insurers to really increase health literacy, sort of not just in this space of the enrollment period, but more broadly going forward. Do any of the speakers have any thoughts on that or any efforts you're aware of?
I can take a quick stab at that. So understanding that education this really is an education campaign when talking about health insurance, because we're educating folks on not only the benefits of the ACA, but how to use the ACA to their advantage. And so understanding that, we actually partnered not only with schools, but with community colleges. We have partnerships with Miami-Dade College, which is the largest community college, but also represents the largest institution with Latino enrollment, as well as several target audiences when reaching young parents, reaching traditional age, young people between 18 and 34. So really going after those organic leaders that already exist within the education scope and having them serve really as a messenger was a key point in both our campaigns, both for OE1 and OE2. As I mentioned, we just closed a series of roundtables that we held across the country with college presidents and superintendents. We've hosted events with Superintendent San Antonio to Morehouse School of Medicine in Atlanta most recently, getting them to become invested in this work because they can play an important role not only in the messaging, but then also in folding in the message within the outreach they do during the school year and also right around open enrollment. So that was one of the ways that we've folded in education and higher ed institutions to ensure that they're doing some of the work and that they're instituting the work within their day-to-day as well.
And this is Cara. I would also add that there are definitely a number of organizations, institutions, and even the government that's working on health literacy and how we can do a better job. I think that some of the challenges that have come out through open enrollment really highlight a larger issue that is happening in our healthcare system where it's not just individuals who are new to coverage, but there are plenty of people who've had coverage for quite a long time and have questions about their coverage, questions about how to take their medication properly, and there are a number of resources that have been developed to help make that easier for consumers to understand. I think, one of the points that Jose mentioned is simple messaging, and so it's, making sure that materials that are developed with literacy in mind, both low literacy as well as health literacy, and so simple communication. There's also a roundtable on health literacy at the Institute of Medicine that has worked to shed light on a number of resources and issues such as health literacy and palliative care, as well as health literacy and cultural competency, and that's available, again, some of their reports that they have developed are available on their website, which is through the IOM at edu, iom.edu, sorry. But I think that this continues to be a challenge and one in which we will have to continue to work on, and as we're moving people into the system to help them really get the best of this, because at the end of the day, we're really trying to improve health outcomes, and health literacy is a critical part of it.
Great, thank you. Melissa, are there any questions over the phone?
Again, as a reminder, if you'd like to ask a question, star 1 on your telephone keypad.
Great. I'll take another web question. And I, from what I understand, I believe Dr. James and Jose, that you have both sort of incorporated feedback from the earlier enrollment periods in terms of developing your tools and information. But this question is about, how and have enrollees been asked why and what information finally convinced them to enroll, and have they asked them whether or not, they trusted the information they were told, and, has it turned out to be true, and kind of thinking about this third enrollment period and sort of, keeping the gains that we've made in terms of the re-enrollment process as people might be choosing different plans and trying to better understand their coverage options.
Mr. Jarek, I'll offer just a few comments. I don't know that I have a specific answer to the question from the perspective of do we have data internally at our company regarding what was really the deciding factor for members. But I would say it's one of the payer that had the largest enrollment in retail across the country. We really found success in partnering with community organizations, trusted partners, to be co-messengers, co-informers, in helping educate individuals regarding the Affordable Care Act and coverage available in the retail markets. And just from my personal experience in talking with individuals and being a part of that process, I think that really helped. I think we can all look back at a lot of the mixed messaging that was ongoing in the public sphere around the Affordable Care Act and what it meant for individuals and what it meant for states. Obviously, a lot of challenges in terms of getting the right messages through that would allow individuals to make informed decisions that would be in their best interest and the best interest of their families. And so I think it was that partnership role that helped give folks the information that they needed, help them to understand, if subsidies were available to them, how to access them and what that really meant. I'll be happy to pass it on to others for comments.
And I would add, I think that, more of the research that I'm familiar with has been asking those who are still uninsured, some of what is the reason for that, more so than those who've got coverage as to why. And I think that, as both Jose and I talked about, there's really some basic information that a lot of the uninsured do not understand. And we talked about the tax credits. I think a big fear regarding affordability of coverage, and there are people who are, very much struggling day to day in terms of their household expenses, but many people don't know that financial help is available, and so helping to get the message out about that. People also, as we talked about, particularly for communities of color, are very interested in that in-person assistance and letting people know as well that there are trained individuals within many of their communities who can help them, and building some of those better bridges and connections are also important in getting more people covered. And, also I think for some people, they also are still confused about the dates. So letting people know when open enrollment starts, that it is just in a few weeks, and that they need to sign up as soon as possible. But I think that, that those are some of the important pieces, and how do we talk to people about some of their big fears regarding cost, the fact that they might feel like they have to do this alone and not knowing that there is assistance available, and particularly on the financial help side.
Yeah, and with our research, what we have found is that, almost half of the uninsured still lack confidence in choosing a plan for themselves. And what ended up happening was that a lot of them chose a plan and got enrolled after multiple touches, but mostly because they wanted to avoid the fine. So even in the messaging that we've done now in English and in Spanish, we are emphasizing the penalty. It's kind of the carrot before the stick, but it's really what has made a lot of folks in the community respond and want to get enrolled. But now what we're seeing on the back end is that over 2/3 of those that are still uninsured don't understand what they are signing up for, and so a lot of them have been doing it to avoid the penalty, but yet it's doubling our work now in terms of explaining what they are signing up for, and not just avoiding a penalty.
Melissa, do we have any questions on the phone?
We do have a question from the line of Captain Benitez McCrary. Your line is open.
Hi, this is Captain Benitez McCrary. Can you hear me?
Yes.
Yes, we can hear
good.
you.
I asked a question about pooling those that have enrolled, because I agree with Dr. Plaza. If the word of mouth in the communities, irrespective of language and economic prestige or level, if they understand what benefit enrollment would give patients and can parlay that message to others, you'll find that the campaigns don't need to be have such intensity, because each patient through word of mouth will talk to another patient about not going to the emergency room, about asking questions, becoming more literate. So I would think that there's an area here that might need to be enhanced, and addressing the patients that are enrolled will help us enroll more patients. And I would call that learning activity and technical assistance to those agencies that are charged with that task. And that's the question comment, but I wanted to thank each speaker for responding to those two questions. Thank you.
And there are no further questions in queue at this time.
Thank you. Well, since we're getting close to the close, or right out the close, I wanted to just ask one sort of closing question and allow the speakers sort of a final comment. So as we've discussed today and has been discussed in the news, the upcoming enrollment period is predicted to be the most challenging yet. We've made a lot of gains, but there's still populations that we haven't reached yet. So is there one message or piece of advice that you would like to leave our audience with today? And we can start with Dr. James and go in order.
Thank you for that, and not giving me the benefit of letting ladies go first. I think, part of the challenge that we are going to find really, I think, speaks to the cost and the affordability, that many of those uninsured who are remaining, cost is a significant barrier. So I would encourage everyone, and even as Ms. McKebby was mentioning, in terms of the peer networks, of getting the word out to help people understand that many of these individuals will qualify for financial help to make coverage more affordable. As we mentioned earlier, many of the uninsured have not even visited the marketplace to find out what they might be available to help them, and I think getting that message out will help to alleviate one of the biggest concerns that a lot of people have about their ability to afford coverage.
Thank you. Jose?
So I definitely want to echo Dr. James's remarks. I think it's also important for us to recognize that we've already reached the low-hanging fruit when it comes to those that lack coverage. And so now it's important that, one, we focus on cost. We focused on simplifying the message. We learned early on that giving a December 15th deadline for January 1st enrollment was important, but we also ended up confusing consumers because then they heard that the deadline was 2 weeks later. And so understanding the challenges that our community face in working specifically with communities of color, we need to empower trusted organizations and trusted messengers in our community to take ownership of this process, because a healthy community really is the best thing that we can do for our communities of color. And so thinking outside of the box as we are trying to reach these other 10.5 million consumers is going to be very important. And then utilize the tools, use resources like NIHCM, ourselves here at Enroll America, and the tools that we are providing, because they are consumer tested, and just ensure that you're able to get the word out and work within the coalitions that already exist to get consumers informed about the benefits of the ECA.
Thank you. Dr. Robinson?
Thank you. I echo the comments of the other panelists, and I'll just note that we remain committed to growing our numbers of insured in the retail markets, and certainly our minority communities remain a significant opportunity for us. And so, we continue to build and strengthen our competencies in working with all of our members, and especially our members in the minority communities. And then certainly we believe in the strength of partnerships with community organizations, and so we'll continue to really grow and build on that strategy as we move into the open enrollment period, and look forward to continuing to help increase coverage and ultimately improve the health status of populations and reduce some of the equity gaps that we see in health status and health outcomes.
Great. Well, thank you all so much for joining us today. We'd like to invite our audience to take a moment to share feedback from this event by completing a brief survey, and also invite you to register for some of our upcoming webinars